Hello and welcome to this video on how painkillers work. It is often simply taken as a given that when you swallow acetaminophen, ibuprofen, opioids or other pain relief that you simply stop feeling pain after a short period of time. The way this happens is nowhere near as simple as it might seem. Pain is a result of activating nociceptors. These are neurons that send a signal that things are hurting. This can be due to heat, chemical, or physical injury. The different nociceptor pathways, receptors, and causes of pain have different pathways, and these can be targeted in different ways. There are four main types we will describe: COX inhibitors, non-steroidal anti-inflammatories, opioids, and local analgesia. Aspirin is a similar function to acetaminophen. It is a COX inhibitor, and the two have similar but slightly distinct functionality. Aspirin is non-selective and it irreversibly inhibits both forms of the COX receptor. This is important. Comparative between the two, it is slightly worse at targeting COX-1, but it does hit both COX-1 and 2. In order to have the effect you see, that is, to stop feeling as much pain, it targets the serine residue and acetylates it. This prevents it from creating prostaglandins. Prostaglandins are pro-inflammatory, and there are also thromboxanes. Thromboxanes are what lead to clotting. By decreasing inflammation, which is one of those things that signals neurons to sense pain, and through altering the clotting pathway, which is another thing that creates a signal of pain, you wind up with much less of a signal being released, if any at all by that point. The aspirin-modified COX-2 receptor also causes the change in production of particular molecules called lipoxins. These have anti-inflammatory properties. The way aspirin works is another reason why it is often used to try and reduce the probability of blood clots in those with cardiovascular disease. By reducing clotting, you can, in theory, reduce the risk of the blood clots developing in the first place. This means there's less risk of a unexpected thromboses. Acetaminophen is another common option and is perhaps the most common at the moment, although ibuprofen is quickly, if not already, taking over. Rather than targeting the COX-1 and 2 gene, it targets the COX-3 gene, and it specifically inhibits the gene from working. It does this by blocking the production of prostaglandins, so very similar to what aspirin does. As with aspirin, without prostaglandins there is no pain, or at least significantly reduced pain. It also reduces inflammation. Without inflammation, you don't have the production of the various signals that lead to other neurons being activated to say you are in discomfort. Ibuprofen is another option, and it is often used at a similar level and with the same readiness as acetaminophen. Where it differs is that it is a non-steroidal anti-inflammatory. This is sometimes given the acronym of NSAIDs. These inhibit the production of cyclo-oxygenases. These are necessary for prostaglandins to be made within neurons and other cells. Without this, there is no synthesis. Ibuprofen works in a similar way to what acetaminophen and aspirin do. It targets the COX gene, but as we mentioned, it blocks the cyclo-oxygenase, which is part of the COX-2 pathway. By blocking locations needed for the COX-2 to be stimulated, it then prevents the expression of prostaglandin, prostacyclins, and thromboxanes, just the same as acetaminophen and aspirin has. Opioids differ drastically from what we've mentioned so far. Not just that they aren't looking at targeting the COX receptors, but what they are doing is somewhat more varied and, to be honest, less well understood. They bind to their own class of receptors called opioid receptors. These are found in the central nervous system, and so they prevent pain from being processed within the brain and spinal cord itself. While there are 4 kinds of opioid receptors, only 3 of them, the mu, kappa, and delta, respond to pain, and so you have different opioids that will target each of these receptors to differing degrees. This differing degree is called affinity, and so you can have drugs that are better at dealing with certain kinds of pain signals than others. There are opioids that are considered agonists of the mu receptor. This is things like morphine and fentanyl. They have analgesic action, that is, they give you pain relief, but they also have an effect of causing euphoria. This can be a mixed result depending on what you're trying to achieve. Kappa receptor targets are good against both kappa and mu receptors. These are things like butorphanol. You then have partial agonists, which are things like your buprenorphine, and they have an analgesic effect on their own. Finally, there are pure antagonists, things like naloxone. These are very good because they effectively block the receptors and don't allow other opiates to have their intended effect. Of these, what you're fundamentally doing is blocking the receptor itself and preventing any interaction in the case of antagonists. In the case of agonists, you're actually stimulating the receptor. Going outside the brain, you have the final major group worth discussing as is, and that's local pain relief, and is another option commonly used because of how well it can be targeted. Local anesthetics work by targeting the neurons themselves in a very local area. Consider what happens if you get something like a root canal done or minor surgery that you don't need to put under sleep for. What they do is that they block the action potential of the nerve, and because the nerve can no longer send a signal along its length, it can't be able to transmit the sense of pain. A very simple but common example, although perhaps not for those who've experienced it, is an epidural. Epidurals prevent signals going along the spine, and so, during childbirth as an example, you don't feel the pain of the contractions and the process of a child being forced out. This means you can have short-acting but very, very effective pain relief. Because it is very local, it prevents all signals, but it also is removed relatively quickly. There's a final group, and it's not so much that it's used for pain relief, but that it has a role, and that role is perhaps why some people make the dumb decisions that they do. That is alcohol. Alcohol interferes with the way neurons work, and so by interfering with neurological actions, you can, to a certain extent, reduce the sense of pain. Now, there's an argument to be had that drinking alcohol is for killing things inside of you, like feelings, and rubbing alcohol is for killing things on the outside of you, like infections. Ignoring the sass, alcohol has its analgesic effect because it interferes with MDA receptors. This is very similar to how opioids work, but it's a different classification. By targeting these MDA receptors, or being antagonistic, it reduces the activity of glutamate. By reducing the activity of glutamate, the movement of signals is drastically and quite significantly impaired, and in doing so, you're no longer able to send a signal saying that pain exists. This is why someone who is drunk may be able to put up more of a fight than someone who is not. Why somebody who is drunk might be able to fall down some stairs and then get up and walk away, despite being quite badly injured. Their sense of pain, along with many of their other senses, are quite impaired, and it's not just limited to pain itself. Rather, it's limited to all of the neurological function, and that's why alcohol, although able to produce analgesic effects, is not a good option. The theoretical benefits are far outweighed by the practical side effects and significant interactions. Painkillers or analgesia are a common and readily used medication, or a class of medications. People take them readily, but the ways they work are nowhere near as well understood, and certainly people take for granted the results of taking such medication, but give little thought to how they interact and what different classifications of medication can be useful for and why. Thank you for watching this video. If you found it interesting, consider liking, sharing, and subscribing. Please post any comments, questions, or suggestions you have below.